Welcome to This Explainer. Today, we're diving deep into a true textbook-level journey through the clinical guide to meningitis. We're going to break down the three major classifications, the specific pathogens involved, and crucially, the rigorous clinical protocols used to treat them. And listen, we're not skipping a single dosage or pathogen today. The goal is to give you everything right here so you won't even need to crack open a textbook later. All right, let's look at our roadmap. We've got 5 main stops: community-acquired meningitis, post-neurosurgical cases, vulnerable populations like those with CSF fistulas or who are immunocompromised, and then we'll wrap up with post-traumatic pathogens and their specific treatments. Let's get to it.
Part 1. Community-acquired meningitis, or CAM.
Okay, right out of the gate, you need to know that CAM is usually a highly fulminant medical emergency. It hits way faster and harder than meningitis caused by surgery or trauma. The pathogens? Well, that depends entirely on the host's immune system. In a healthy adult, you're looking at the heavy hitters: Neisseria meningitis, Streptococcus pneumonia, and Haemophilus influenzae type B. But if the host's defenses are impaired, even much less virulent bugs can take over. Interestingly enough, focal neurologic signs are actually pretty rare in acute purulent meningitis. What you really need to be on high alert for is increased intracranial pressure, or ICP. Now I want to talk about a literal nightmare scenario: Waterhouse-Friderichsen syndrome. This happens in roughly 10 to 20% of children dealing with a meningococcal infection, usually when it's disseminated. The clinical picture is just incredibly stark. We're talking massive petechial hemorrhages across the skin and mucous membranes, soaring fevers, septic shock, and most terrifyingly, acute adrenal failure, because they are actually hemorrhaging directly into the adrenal glands. Plus, they're often battling DIC at the same time. It's an absolutely critical emergency. Because of severe risks like that, CAM requires immediate aggressive action. But here's the absolute golden rule: timing is everything. You have to start with corticosteroids, specifically IV betamethasone at 0.12 milligrams per kilogram or dexamethasone. And you literally cannot mess this sequence up. The steroids must, without exception, be given before or at the exact same time as the very first dose of antibiotics. If you kill the bacteria first, the resulting massive inflammatory response can be devastating. Sometimes meds just aren't enough, right? When things escalate, we have to look at neurological interventions, like an external ventricular drain, or EVD. We use this for comatose patients who aren't localizing pain. It lets us directly measure and manage elevated ICP, or ventriculitis, and it's a great route for delivering intrathecal antibiotics. Now, if the ICP just refuses to drop despite meds and draining CSF, you have to seriously consider a decompressive craniectomy. Also, keep in mind that an EVD is often essential for acute hydrocephalus, which you'll actually see pretty frequently when treating cryptococcal meningitis. All right, Section 2, post-neurosurgical procedure meningitis, pathogens and protocols. When we shift into the post-surgical world, the bugs change completely. We leave the community-acquired stuff behind. Now we're dealing with opportunists: Coagulase-negative Staphylococcus, Staph aureus, Enterobacteriaceae, and Pseudomonas species. Pneumococci are on this list too, but here's a huge clinical pearl: they almost always show up in association with basilar skull fractures and otorhinologic surgeries, so keep an eye out for that specific combo. Okay, let's talk dosing, because getting this right immediately is non-negotiable. For your standard empiric therapy, you're hitting them with vancomycin at 15 milligrams per kilogram IV every 8 to 12 hours. You want to aim for a trough of 15 to 20 milligrams per deciliter. You pair that with cefepime at 2 grams IV every 8 hours. Simple enough, right? But what if they have a severe penicillin allergy? You have to pivot. You drop the cefepime and swap in either astrianam at 2 grams IV every 6 to 8 hours, or Cipro at 400 milligrams IV every 8 hours. If the infection is exceptionally severe, you've got to step it up to daily intrathecal therapy, and I cannot stress this enough: you must use strictly preservative-free drugs, period. Your options here include vancomycin, tobramycin or gentamicin, amikacin, and colistin. Once those culture sensitivities finally come back, you streamline. So if it's methicillin-sensitive Staph aureus, MSSA, you immediately ditch the vancomycin and switch to oxacillin or nafacillin. Oh, and one more thing. Always keep chemical meningitis on your differential when dealing with post-op patients. Moving on to Section 3, CSF fistulas and immunocompromised hosts. When a patient has a specific structural or immune vulnerability, the pathogens totally change the game. If you suspect a CSF fistula, your prime suspects are usually streptococci. But if you have an immunocompromised host, say an AIDS patient, the threat list expands massively. You have to worry about every single post-op bug we just talked about, plus a whole new terrifying roster: Cryptococcus neoformans, M. tuberculosis, HIV aseptic meningitis, and Listeria monocytogenes. Cryptococcal meningitis is a massive threat for those immunocompromised patients, so let's break down the exact multi-phase treatment protocol. It's a marathon, not a sprint. First is the induction phase, lasting at least 2 weeks. Liposomal amphotericin B at 3 to 4 milligrams per kilogram IV daily, alongside oral flucytosine at 25 milligrams per kilogram 4 times a day. Then you move to the consolidation phase for a minimum of 8 weeks, using 400 milligrams of oral fluconazole daily. Finally, they step down to chronic maintenance, just 200 milligrams of oral fluconazole every day. Okay, Section 4, post-traumatic pathogens, specifically focusing on craniospinal trauma.
So what does a typical post-traumatic meningitis patient look like? Well, this occurs in about 1 to 20% of patients who take a moderate to severe head injury. Usually it hits fast, within the first 2 weeks post-trauma, though delayed cases definitely happen. But here's the real smoking gun. 75% of these patients have a clearly demonstrable basal skull fracture. And over half of them, 58% to be exact, have obvious CSF rhinorrhea. That means cerebral spinal fluid is literally leaking into their nasal cavity.
And that nasal connection, that tells us exactly what kind of organisms to hunt for, because the trauma essentially grants the patient's own nasal flora a VIP pass right into the central nervous system. Look at this data from a Greek series. For gram-positive cocci, it's Staph hemolyticus, Wernerii, Coni epidermidis, and strep pneumonia. For gram-negative bacilli, we see E. coli, Klebsiella pneumonia, and Acinetobacter anitridis. It's all about what's naturally hanging out in the nasal passages.
This brings us to our final section, number 5, post-traumatic treatments and controversies.
First up, the amphoteric antibiotics. For trauma patients, you go in hard and fast. The protocol is vancomycin at 15 milligrams per kilogram IV every 8 to 12 hours, keeping that trough exactly between 15 and 20. But this time, you pair it with meropenem at 2 grams IV every 8 hours. Why meropenem? Because this specific combo offers absolutely stellar CSF penetration and perfectly covers the broad spectrum of nasty pathogens these trauma patients are prone to. Now, if a patient has a CSF leak, the vaccination timeline becomes incredibly strict. Let's look at pediatrics first, ages 2 to 18. In the US, routine vax means they should already have PCV13 at 2, 4, and 6 months, plus a booster at 12 to 15 months. If they miss that, step 1 is a single catch-up dose of PCV13. But here is the mandatory part for the leak itself. They must get 1 dose of PPSV23, which is pneumovax, exactly 8 weeks or more after any prior PCV13 dose. No exceptions. The adult protocol is slightly different. If a patient is 19 or older with a leak and their history is spotty or totally unknown, start them with 1 dose of PCV13. Just like the kids, you follow up with 1 dose of PPSV23 at least 8 weeks later. But adults have a unique requirement down the road. Once they hit age 65 or older, they need 1 final dose of PPSV23. And remember, that final shot has to be at least 5 years after their most recent PPSV23 dose. Okay, here is where things get heavily debated in the medical community. How do you actually manage the CSF rhinorrhea itself? The surgical camp says you explore every single case. Their logic? If a leak suddenly stops on its own, it might just be sham healing. Basically, a piece of brain tissue gets incarcerated and temporarily plugs the hole, creating a massive, hidden risk for a blowout leak or severe meningitis later on. On the flip side, the conservative camp argues that spontaneous cessation is totally acceptable. They'll often just use a lumbar spinal drain to relieve the pressure and let the tissue heal naturally.
Whichever side of that debate you're on, there is a hard and fast consensus on the final treatment protocol for the infection. You absolutely must continue IV antibiotics for 1 full week after the CSF is officially sterilized. If that week ends and the patient is still dealing with persistent rhinorrhea, the conservative approach is out the window, and surgical repair is definitively recommended.
So, we've walked through the classifications, nailed down the dosages, and decoded the rigorous protocols for every twist and turn this dangerous condition can take. But I want to leave you with a thought. When we choose to treat these post-traumatic leaks conservatively, are we vastly underestimating the long-term hidden risks of sham healing? Does skipping the OR today just plant a ticking time bomb for severe, deadly meningitis tomorrow? It's a massive question, and one you need to weigh carefully. Thanks so much for joining me on this explainer. Keep studying and stay curious.